All right. Hello. My name's George Minowata. I'm a volunteer physician for MAVEN Project and your moderator. Thank you all for joining us today. And our friends at Generations Family Health for hosting today's session titled What a Primary Care Provider Needs to Know About Chronic Kidney Disease. Our speaker today is Dr. Lucius Wright. Dr. Wright became medical director of the dialysis unit at Brooke Army Medical Center and then director of the Nephrology Fellowship there. After separating from the Army, he went into practice with the Jackson Clinic in Jackson, Tennessee, where he established the nephrology service. Dr. Wright retired after 35 years of practice. During those years, he also served as the clinic's chairman and then the medical director. Dr. Wright, the microphone is yours.
Well, good morning, everybody. I'm impressed at how many of you managed to get up despite not having time for a third cup of coffee. Hopefully, I won't put you to sleep. My plan for the next half hour or so is to give you a presentation on some of the newer information about chronic kidney disease, which hopefully is a review. There's plenty of time for questions at the end because I'm convinced the most important teaching takes place when we talk about your patients as opposed to the ones I chose to talk about. See if I can get my slides to advance here. There's no conflict of interest to disclose. And as he's already said, this is approved for 1 hour of AMA PRA Category 1 credit. So my objectives are to have you understand what the estimated glomerular filtration rate, henceforth known as eGFR, tells you about your patient, because I've discovered that there's some misunderstanding about that. Understand the importance of measuring proteinuria and what it tells you about diagnosis, prognosis, and the treatment of your patient. Understand the basic approach to delaying progression of chronic kidney disease in patients at risk using ACE or ARBs, SGLT2 inhibitors, GLP-1 inhibitors, and finerenone. And then recognize your role in helping patients achieve a dialysis last or dialysis never, as opposed to a dialysis first outcome. Let's start with a case to try to help make this make more sense, since we're all used to working with real patients as opposed to listening to boring lectures with lots of slides. A 36-year-old male presented to the local emergency room with a case of severe laceration to his arm sustained in a motor vehicle accident. He was noted as part of his initial physical exam to have hypertension, with a blood pressure measured around 190/110 on multiple occasions. The basic lab was drawn showing a hemoglobin of 13.2 with normal indices, normal electrolytes, a BUN of 24, and a creatinine of 2.1. He's been referred to your clinic for follow-up of his acute kidney injury. So the first question we need to ask ourselves in a case like this, is this really acute? Bear in mind that acute kidney injury results in upcoding for hospitals, so there's a bias toward calling it acute. When I was young, we used to and had to write our notes by hand. I know this back in the days when dinosaurs roamed the earth. WNL meant we never within normal limits, but sometimes it meant we never looked. Things that you should look for if you're trying to decide if this is acute or chronic include the past medical history. Was he ever really sick as a kid, or told he had hypertension or an abnormal urinalysis, say when he went out for a sports team in high school? Family history. There are new observations about family clustering of chronic kidney disease. Up to 50% of CKD in kids has a genetic risk basis, and probably about 20% in adults, depending on the population. Genetic testing and counseling are still not ready for prime time outside of a research grant, in my opinion, but there are people who are pushing this. I haven't found that in the one thing we know about well, autosomal dominant polycystic kidney disease, that the results of screening tests impact what people decide to do about having kids. Autosomal dominant polycystic kidney disease is indeed the primary prototypical hereditary kidney disease, and there are two markers that are testable genetically, PKD1 and PKD2. There's an old myth out there that the families have a typical time to develop end-stage kidney disease. Granddaddy went on dialysis when he was in his 40s, so therefore I will. That's not true. And remember that pain, hematuria, and enlarged kidneys may not be a cancer, although I've seen more than one patient who had a nephrectomy done for suspected renal cell cancer who turned out to have polycystic kidney disease. There's some newer non-traditional markers that, again, are not ready to be easily measured in prime time, but it's worth thinking about it, because those of us who've been in the business a long time recognize that we have whole families of people with chronic kidney disease who do not have the classic genetic diseases. And these are ApoL1 and myosin 9, myosin heavy chain 9, which are markers that are more frequent in people with sub-Saharan African ancestry and in locations with high frequencies of endemic trypanosomiasis. So, estimated glomerular filtration rate. What's the issue? Why did I bring that up as one of my primary learning objectives? The measurement of glomerular filtration rate is central to diagnosis and treatment of chronic kidney disease, and it's an indicator of timing for clinical decisions, now codified in the stages nomenclature in the ICD-9 formulas. The current lab formula is based on a newer method for measuring creatinine. It's not new, it's 30 years old. Now to the second decimal place compared to earlier versions, which only measured it to 1 decimal point. The formula was published in conjunction with the modification of diet and renal disease study, and was originally published with adjustments for Black race and all others. That's been changed, and it makes some difference when your lab changes over, but most clinical labs have begun to change over, and so you shouldn't have to worry about it going forward. The point I do want you to remember is that E stands for estimated. It's not a lab test, it's a calculated value. If it matters, measure the glomerular filtration rate or consider using an alternate marker such as cystatin C. And we'll talk about that a little bit more later. Urinalysis is important, but interestingly enough, in the consults I get from MAVEN Project members, I find that we frequently have lots of lab and sometimes x-rays, but sometimes don't have a simple urinalysis. Bear in mind that cellular elements can be very important. Red cell casts, for instance, are almost diagnostic of glomerulonephritis, but are rarely seen. White blood cells are more common, but there's a tendency to write it off as a urinary tract infection, but it may or may not be. And granular casts, which are also commonly seen, are nonspecific and usually related to the amount of proteinuria. I've mentioned protein several times, and let's talk about it a little bit. The gold standard is still the 24-hour urine collection, but it's hard to do. So we've substituted urine protein and now urine albumin and creatinine ratios as a substitute. If you're going to do a screening spot urine test, do it on the urine albumin creatinine ratio. It's more sensitive and probably more specific. Is it a marker of disease or a marker of prognosis? And the answer is both. And it does have implications for screening. Is it a therapeutic target? In my opinion, the answer is often yes. And we're going to talk about a brand new study that was published 2 weeks ago in the New England Journal that uses reduction of proteinuria as a marker of response to the therapy. Here's a funny looking slide because the albuminuria is in strange units called micrograms per minute. All you really need to remember is that it gets more proteinuria the further to the right you go on the x-axis. And on the y-axis is a logarithmic scale of hazard ratio for cardiovascular disease. And the point of this simple slide is to point out that the risk of cardiovascular disease goes up as the amount of proteinuria goes up. So by the time you get to nephrotic range proteinuria, the cardiovascular disease risk is somewhere on the order of 2.5 times greater than it would be in a population without proteinuria. So it's a marker of other comorbidity, particular vascular disease, and that's something we'll talk about some more too. What you and the patient both want to know is what's the risk of developing end-stage kidney disease and needing to be dialyzed or have a transplant. There are 4-factor and 8-factor models out there. The 4-factor model is good enough for government work. And it looks at age, gender, EGFR, and the urine albumin creatinine ratio to predict risk. There are 2 of them that are online. All you got to do is Google KFRE calculator and they'll show up. They'll also be on the slide deck that you'll get tomorrow. When you do this, you'll find that the 2 and 5 year predicted risk of kidney failure in a lot of your patients is a lot lower than you think. And they all overestimate the risk of end-stage kidney disease because of competing risks of death from the cardiovascular causes, which takes us back to the previous slide that looked at the issue of cardiovascular risk as a function of proteinuria. There's some other diagnostic considerations. Is this primary kidney disease or secondary kidney disease? There are more diseases, primary diseases that have specific therapy, such as membranous glomerulonephritis, minimal change disease, and rapidly progressive glomerulonephritis. So if you have reason to be suspicious of that, you ought to consider expert consultation, kidney biopsy, workup, and let them decide what to do because the therapies are changing constantly. Secondary, which is the one you're more commonly going to see in the clinic, is mostly diabetes and hypertension in the United States. Screening for collagen vascular diseases with things like an ANA and complement levels is common, but may not be cost-effective without clinical symptoms. And of course, I know all of you are trying to practice cost-effective medicine since your patients tend to be underinsured. Screening for cancer, which is associated with chronic glomerulonephritis in adults, has the same problem. There are some genetic markers out there like thrombospondin 7A, which are more commonly associated with cancer, but the PLA2R marker, which is the most common, is present in about 70% of adults with biopsy-proven membranous. Again, I don't think this is something you need to remember, but just something to give you some idea of the complexity that you can get into with diagnosis and treatment. Worldwide, infectious diseases are still a common cause of chronic glomerulonephritis, including syphilis, hepatitis B and C, and HIV. And malaria is probably the most common worldwide, but very rare in this country. But again, you see a lot of patients who grew up in other countries. So you need to keep in mind some of these more uncommon diseases. So what I've said so far is that genetic factors are important, particularly in patients with African ancestry. Proteinuria is important, albumin being more sensitive than proteinuria for both diagnosis and prognosis. Kidney failure risk equations are available to estimate the 2 and 5 year probability of end-stage kidney disease, but they overestimate the real risk because of deaths from coronary artery disease. I've told more than one patient that my goal is to keep them alive long enough for something else to get them, and they actually appreciate that, even though it sounds a bit macabre. Remember, the eGFR means estimated glomerular filtration. It's useful as a guide, not an absolute, and the clinical status of your patient matters in decision making. So don't get focused on the numbers to the exclusion of the patient. So what should you be doing for your patient? Well, obviously, the first thing you'd want to do is blood pressure control, just like you would in anybody else. Diabetes control if they have diabetes. You want to avoid nephrotoxins as much as possible, which includes non-steroidal anti-inflammatory drugs and proton pump inhibitors, which patients can get over the counter without help from you. And proteinuria reduction using an ACE or an ARB, although not both. Mineralocorticoid receptor antagonists, SGLT2 inhibitors, and the GLP-1 agonists. And we'll talk a little bit about the data behind each of these. Some thoughts on hypertension. Using an ACE or an ARB is desirable, but cost and hyperkalemia can be issues. Volume control is the key issue, particularly in patients with CKD stages 4 and 5, and you're going to usually need to use a loop diuretic as thiazides don't have much effect once you're at CKD 3 or greater. An exception may be indapamide in a patient with no evidence for volume expansion, and perhaps chlorothalidone, although chlorothalidone was used as add-on therapy in the study that was published a couple of years ago, not as a standalone drug. Diuretic resistance occurs commonly in patients with nephrotic syndrome because the loop diuretics work from the inside of the kidney. Metolazone, which is commonly used in that situation to boost the effect, is probably additive by a direct action on the distal convoluted tubule to increase distal delivery of the loop diuretic. Again, the thing to remember is these patients can be hard to manage. Is there a blood pressure target that really makes sense? The SPRINT final report, which was published 4 years ago now, she looked at a very large number of patients with hypertension who were at increased risk of cardiovascular disease, had no history of diabetes or previous stroke, and randomized to receive intensive, meaning systolic blood pressure less than 120, as compared to usual blood pressure goals of systolic blood pressure less than 140, and were followed for 3 years. The primary result was expressed as a composite outcome of heart attack, acute coronary syndrome, stroke, congestive heart failure, and death. The composite event rate was actually fairly low, even though this was an enriched population of people thought to be at risk. And it was 1.77% annually in intensive versus 2.4% in the usual level. So it's an absolute reduction of 0.63 events per year. And if you convert that into the number of patients you need to treat in order to show benefit, you have to treat 159 patients to show a benefit. All-cause mortality was 1.06 in the intensive versus 1.44% in the usual. which is statistically significant, but an absolute reduction of 0.38 deaths per 100 per year. So the number needed to treat goes up to 263. Adverse events increased in hypotension went from 1.2 to 2.1%. Syncope went from 1.6 to 2.1%. And acute kidney injury went from 2.5% to 4.1%. So it's an absolute reduction in the usual group of 1.6 episodes per year, or a number needed to harm of 63. So my conclusion from this is that lower targets have lower event rates over the intermediate term, but at the cost of increasing complication rates, particularly hypotension and acute kidney injury. So as always in clinical medicine, it's a matter of patient selection. You have to consider the goals of treatment, competing risks, and tolerance of medical therapy. We're fond in medicine of what I call the more is better theory of medical care, but it's rarely true. Remember, aging occurs in everyone, albeit at different rates. And the goals for medical care change with age and comorbidity, so you need to keep updating. And that's where you as primary care physicians have a major role to play in the treatment of this group of patients. The instance that I would say is a clinical example, if you had a 40-year-old person whose only real problem was their chronic kidney disease, I'd probably be very aggressive in using anything I thought would help to try to stabilize their kidney function and keep them off dialysis as long as possible. If the patient's 85 years old and one step away from the nursing home, I might be content just to keep them comfortable and out of the hospital, which might be a completely different goal in terms of what kind of medicines I would use. And I think that as primary care providers, you're all much more aware of the problem of polypharmacy and drug interaction than the academicians who write the studies and the guidelines. Common clinical question I get in consults from MAVEN Clinic folk is a patient who's got AKI, maybe or maybe progression of chronic underlying kidney disease, and they're using a RAS. So basically, the studies show a 30 to 50% relative risk reduction for end-stage kidney disease in patients with an eGFR greater than 30. So the usual risk is somewhere to 3 to 5% over 5 years, and the number needed to treat is approximately 100, which is kind of a break-even point. But the question that comes up is, do patients benefit or are they harmed by continuing their RAS inhibition as their CKD progresses, which it sometimes does? Let me remind you of a couple things that you probably know, but it's always good to see a picture to remember. This is the relationship between creatinine clearance on the x-axis and plasma creatinine on the right. And what you can see is when the creatinine clearance goes from, say, 120 to 60, the creatinine goes from, say, 1 or 0.9 to about 2 or thereabouts. So most of the change in kidney function occurs when there's very little change in creatinine. But this converse is true at the lower end. So by the time you get to CKD4 with a GFR less than 30, your creatinine is going to be 3. And if it goes to 6, you've only gone from 30 to 15. So these are things to keep in mind. And the second thing to keep in mind is the kidneys manifest something called autoregulation, which you may have studied back in physiology 100 years ago. What it says basically is that over a wide range of mean arterial pressure and renal blood flow, kidneys are capable of adjusting the afferent and efferent arterioles of the glomerulus to maintain stable renal blood flow. But if you get down here on this end of the scale where your blood pressure is too low, this begins to fall off. And that's where you get the acute kidney injury a lot of times in the patients that you're treating aggressively. So just stopping RAS and CKD matter. This is a study published in 2022 that looked at 411 patients in the United Kingdom with CKD 3 or higher who were randomized to stop. Their headline conclusion, which I've quoted here, is among patients with advanced and progressive chronic kidney disease, discontinuation of RAS inhibitors was not associated with significant between-group differences in the long-term rate of decrease in eGFR. End-stage kidney disease or the initiation of renal replacement therapy occurred in 128 patients in the discontinuation group and 115 patients or 56% in the continuation group, which was not statistically significant. Adverse effects were similar in both groups with respect to cardiovascular disease and death. So my basic approach to this study would be to say, if you've got the patient on a RAS inhibitor, and they're doing fine and their potassium is not a problem and their kidney function has been deteriorating slowly, I'd probably leave well enough alone. but whether they'd benefit from stopping or not, probably not. Another study done by Koo and Associates looked at the same question in more advanced chronic kidney disease published last year, which was a meta-analysis, which is always difficult, but looks at more patients, with 1,739 of them in this case, with a mean glomerular filtration rate of 22. The hazard ratio for renal replacement therapy with RAS inhibition was significantly lower than the patients who did not get RAS inhibition, but there was no effect, excuse me, no effect on mortality risk and no observed interaction with age, EGFR, albuminuria, or diabetes. In other words, you can't predict who's going to benefit. It just seems to be a class effect that's out there. So there you are. These slides are hard to read, but what you really want to look at is in the top left. This is from the Koo study. And you can see that unadjusted compared to the group that was not treated with RAS inhibition has a much higher rate of cumulative instance of GFR renal replacement therapy, which is at 36 months, is about 40% versus about 30% in patients who were treated. The other slides show essentially the same thing, looking at different data. So the conclusions are that lower blood pressure targets have lower event rates over the intermediate term, but at the cost of increasing complication rates, particularly hypotension and AKI. ACE and ARB are recommended and may be beneficial in advanced chronic kidney disease, but as always, it's a matter of patient selection. And we're back to reminding everybody to consider the goals, competing risks, and the tolerance of medical therapy. And yet again, if more is better is not always true. And we do need to keep in mind what the patient's goal is and what your goal should be for treating that patient. So you still need to individualize in spite of the guidelines. Dapagliflozin was first reported now almost 5 years ago as a patient with chronic kidney disease. And this study changed a lot of what we do. Looked at a very large number of patients, both with and without diabetes, with moderate kidney disease, and urine albumin creatinine ratios that were increased. The composite endpoint was a decline of an estimated GFR of 50% or greater, end-stage kidney disease, death, and the trial was stopped early when the hazard ratio in the treated patients was 0.56 in the treated versus the control. Death occurred in 101 patients on the drug, 4.7%, versus 146, 6.8% on placebo. So here again, what you have is not an absolute benefit in terms of the time to dialysis, but a relative risk reduction, a hazard ratio. So we've got the same basic problem. The SGLT2 inhibitors in diabetic renal disease seems to be additive when combined with an ACE or an ARB, and that's the way it's generally done. Remember, it is associated with a natriuresis, which is part of its mechanism of action, why it's particularly good in patients with heart failure with reduced ejection fraction. But it's also associated with acute kidney injury, especially in patients who are on ACE and ARB because of that renal autoregulation phenomenon. They're costly. And then, of course, you got the question of SGLT versus GLP-1 inhibitors for heart disease. And that's one that's still up in the air. There is a recent large population-based study from Taiwan that looked at the question of primary treatment of diabetic nephropathy with an SGLT2 versus a GLP-1. And what they found was the SGLT2 seemed to be better from a kidney perspective, but not necessarily better from a heart or survival perspective. Risk for SGLT2 inhibitors include Fournier's gangrene and maybe peripheral neuropathy and amputation risk. How real these are remains to be seen, but urinary tract infections are certainly more common given the fact that you've got all that glucose in the urine. And I would want to remind you that you will get glucosuria when you're taking these drugs, so don't be shocked when you see it on your lab report. A study published almost exactly a year ago called the FLOW study looked at the effects of semaglutide on chronic kidney disease in patients with type 2 diabetes mellitus. They looked at again at a very large number of patients, 3,533. The admission criteria were very similar to the DAPA study. Primary outcome was major kidney disease events, which is essentially the same. And there was a 24% relative risk reduction in the treated group and a mean decrease in EGFR that was lower at a rate of loss compared to the control, and 20% relatively lower relative risk of death from any cause. Now they showed this as a slide, which is a little hard to project because I couldn't enlarge it, But what you want to notice is something right up here at the top, a phenomenon that I wasn't really aware of until this study was published, which shows that when you first start the semaglutide, kidney function actually gets worse for the first couple of months. And we're talking about a year out in some cases. Then it tends to get better, and then it slowly deteriorates at a slower rate than placebo. So I've seen several consults now where patients were started on several changes in medication, including a GLP-1, and showed a decline in creatinine, which may be related to this phenomenon. I've not seen a convincing explanation for what's going on. It seems to be more than just weight and volume, so there's something else happening, but to be determined would be the way I'd look at that. So what I've said to this point is that blood pressure control with an ACE or an ARB help delay progression. The goal is debatable, but the guidelines usually recommend the sprint targets using standardized blood pressure measurements, not usual care blood pressure measurements. Now let me comment on that because it's an important point to be made here. In the sprint studies, what they did was they took the patient back into a quiet room, dimly lit, let them put on headphones with their favorite choice of quiet music, and used an automated blood pressure cuff to take 3 readings, and they averaged them. Now, that's not how I get my blood pressure taken when I go to the doctor, and I bet it's not when you do either or in your office. You walk in, the nurse slaps the cuff on, takes your blood pressure, and then starts talking to you about whatever it is you're there to talk about. So the differences obviously should be real, or they wouldn't have bothered to do it that way. And the answer is that it's somewhere around 8 millimeters of systolic. So 140 over 90 may not be too different from 125 over 80 if you can compare blood pressure measurements. So that's another hooker, another fly in the ointment, and another reason to be cautious about deciding how to use these drugs in patients with lots of comorbidities. The SGLT2 inhibitors are the hot new kids on the block. They're being more widely used now in both diabetic and non-diabetic diseases. And GLP-1 antagonists have obviously enjoyed a boom in popularity, although I understand the manufacturer shortage has been resolved. And there's a drug we haven't talked about called finerenone, which is an aldosterone antagonist, which has benefit in diabetic nephropathy, but hasn't become widely used yet. There was a study published 2 weeks ago tomorrow in the New England Journal of Medicine that looked at the 3-way study of patients who were treated with an ACE and an ARB or an ARB alone versus those who were treated with a semaglutide, and then those who were treated with both semaglutide and finerenone. And what they showed over a period of 6 months is that there was a reduction in the amount of proteinuria. This study is important because the study was accepted for publication in the New England Journal using a surrogate outcome, reduction in proteinuria, rather than a hard outcome, the change in kidney function, or death, which has not been previously done. So you're going to see more of these kind of studies. But as I've tried to suggest, studies that show reduction in proteinuria show benefit, but they show benefit over long periods of time, and you have to treat a lot of patients in order to get benefit. So again, you have to figure out whether your patient benefits or not. Well, as I've said earlier, one of the issues is renal replacement therapy. Remember, dialysis and transplant are difficult medical regimens for the best patients to follow. In a hospitalized setting, I used to see my cardiologist in particular say, "Oh, we won't worry about it if we get kidney failure, you just dialyze them." Neither the patient nor I thought that was necessarily the right answer. The process involves restrictive diets, complicated drug regimens, dialysis 3 times a week with hemodialysis or daily for peritoneal dialysis, clinic follow-up for transplant, and lifelong medications. So the questions I would want you to be thinking about is your patient a candidate, and what can your patient expect on average? Now, obviously, you're not going to be expert and counsel them on individual risk, but if you have a generic idea of risk, you can give them good ideas on going into the meeting with a nephrologist. This looks at the results from 2001 to 2021 on the ESRD prevalent mortality, or the number by modality, I should say. And what you can see is the number of dialysis patients through 2021 was going up. More recent data show a blip, which we'll see in the mortality statistic here in just a second. It shows essentially the same thing. There was a dip in COVID years, but it's gone back up. And if you take out COVID, you can see the rate of increase is about the same. So the prevalent count at the end of 2023, which is the last I was able to find data for, we're talking about more than 800,000 patients. Mortality was improving back in 2011. The mortality rate was around 15% for the best patients. For patients who are at average risk, the ones that are all ESRD, the ones on hemodialysis, the risk was about 17%, got down to around 15% and 16%, then went up with COVID. We seem to be getting over the COVID blip, but COVID did wreck the populations of dialysis patients more than it did other people. A question I'm sure is sometimes top of mind when seeing these patients with funny looking lab tests is if the patient is acutely ill, you should consider referral to a nephrologist. If the patient has an active urine sediment, meaning lots of cellular elements and lots of protein, renal biopsy and aggressive therapy may be indicated. And this would be somebody who has with more than 300 milligrams per gram of microalbumin. So you might consider referral in that situation. In the patient we started with who had incidental discovery of a creatinine of 2, referral is not urgent, but he does need a urine albumin or protein for determining ESKD risk, which I would predict would be low. Remember that as a nephrologist, they or I don't have any tools for medical management that you don't have. I suggest monitoring lab quarterly for a while till you get the idea of the tempo of disease, but if it's stable, you can drop back to maybe twice a year. If the patient is a candidate for renal replacement therapy, it's okay to wait till they get to stage 4 because a lot of stage 3 patients don't progress, about 80% don't, but only time will tell. And if they are progressing and you know it under observation, you can refer them electively at any time. I do need to have a word, since this is the MAVEN clinic group, about dialysis care and the problem of what the government refers to as an undocumented alien. And this is not meant to be a political statement or a discussion of the political issues, pros and cons of immigration, but simply an observation that dialysis care is funded mainly by the federal government, which bars reimbursement for treatment rendered to undocumented aliens. In other words, people who are here without papers. Some hospitals that get disproportionate share payments may provide emergency treatments defined as pulmonary edema, severe hyperkalemia, or overt uremia, but not routine dialysis. And that's been the case in 40 to 50 states. And I have no idea what current political changes are going to do to that. There are two positions on this issue. One is that regular dialysis is a standard of care and is a just approach. The other says, do we have the right to spend other people's money? Because somebody's going to pay for the treatment if you do it, whether it's the government or the patient. I don't know the right answer to that, but I do think it's the right question to ask. So let me summarize what I've tried to say. When working up a patient with a newly discovered elevated creatinine, remember to assess the proteinuria. Treat the hypertension as close to 125 over 80 as you can get without side effects. Use an ACE or an ARB and loop diuretics plus whatever else you need to do to get the job done. Remember, the eGFR is just an estimate. It's a calculated value, not a measured value. So it should generate thought, but not necessarily action. As the primary care provider, you have the role to play in assessing your patient's suitability for dialysis. Have a real conversation and don't take the view that of course you'll do dialysis when the time comes. No dialysis is a viable option in the right circumstances. Well, with that, I'm going to stop and get back to the full screen view where I can see everybody. And we'll do questions and comments. I know we blew through a fair amount in a hurry, but we've got about 20 minutes where we can answer your questions, which, as I said at the beginning, is what I think is the more useful part of this conversation.
Thanks, Dr. Wright, for a great presentation. Are there questions? Again, please use the Q&A or the raise hand feature if you have any questions. I've got one question, Dr. Wright. For those patients on, who make the decision to, go on to dialysis, is the thought that what percentage is that, the last treatment step, and what percentage is it a bridge to transplant? Do you have any kind of ballpark numbers for that?
The transplant rate is about 8% of the population, prevalent population per year, and it's concentrated almost exclusively in the younger, healthier part of the population. So the number of patients under the age of 40 with primary glomerulonephritis as their primary kidney disease has actually gone down over the last 30 years because of transplant being available. They frequently have brothers and sisters who are still alive and healthy and can be donors. the average patient who starts dialysis in this country is 60, has diabetic kidney disease, 40% of them is not really a good kidney transplant patient, and the likelihood of getting transplanted is somewhere on the order of 5%. So the younger, healthier patients, dialysis is indeed a bridge. And in fact, it makes some therapies like peritoneal dialysis, which we haven't talked about at all today, a useful bridge, although it may not be a 5 or 10 year technique in most patients. So it'd be something to actively consider in somebody who's a transplant patient. Preemptive transplant, getting a transplant without going through a step of dialysis first, can be done. Isn't done commonly because you have to have a family donor most of the time to make that happen. And there's some financial problems with making that get paid for. If you start dialysis, you become eligible for Medicare at 91 days as a rule. And Medicare will go back 60 days to pick up people who get transplanted. So starting dialysis can activate the insurance mechanism so you can pay for the transplant, and more importantly, the transplant medications, which are very expensive.
Okay. Still, I don't see any questions.
They're still getting their second cup of coffee down, I'm sure.
Yeah. The another question. So the data on semaglutide is do you think it's a class effect, or is there any data on other GLP-1 agonists?
My guess is it's going to be a class effect, but I haven't seen
Hmm.
that specifically looked at.
Okay.
I think ACE and ARBs are class effects. I think the SGLT2 inhibitors are class effects, although dapagliflozin was more widely studied in a lot of these reports because it was first.
We have a quiet group. There are a
It's too
lot of.
early in the morning.
Well, I think they're two uh, you know uh, safety net clinics, because I can't say FQHC that easily. It doesn't roll off my tongue. I think one's in Connecticut, and I think that's the the anchor clinic, the sponsoring clinic. And then there's one in San Francisco. But
Those folks in Connecticut should be starting to think about lunch, or at least a tea party, as we say in the South. So
yeah. If they're in the UK, it would definitely be tea time. Uh, it is definitely the Connecticut. It's the Connecticut folks. Right, right,
they admitted they're still there, so that's good.
yeah. And so, other than polycystic kidney disease, there's it sounds like there's nothing to screen for in general, in terms of genetics.
No, I'm not sure that's true. What is true is I'm not sure what you do with the data. So
Oh,
if you're seeing a person with chronic kidney disease, depending on your referral population, the primary kidney disease, maybe as much as 25% of them have a genetic component. But what do you tell the kid? Because it's not it's not a classic Mendelian thing. It's more of a risk propensity kind of thing. So, if you have somebody who's got a family history of chronic kidney disease, okay, somebody asked a question, I'll get back to that one. If you get
all right. So
trying to figure out what to do with it is where it gets to be a problem. So if you do it and patients are still in the childbearing age and trying to decide whether they want to take the risk for more kids or not, that would be a reason to do it. But my experience has been that most patients don't factor genetic risk into the decision to have kids.
yeah, particularly if there's incomplete penetrance, that's
Yes.
problematic. Yeah. All right. So we're getting some questions in the chat. All right. So what are your thoughts on monitoring PTH, vitamin D, calcium, and phosphorus? When should that begin for someone with CKD?
I'm going to say I'm going to tell you something that's probably heretical, but it depends. The standard answer that what the board answer to the question is you started about CKD4. And what you have to remember is if you order a renal profile, you'll get a phosphorus, whereas if you order a Chem 18 or a Chem 20, you won't. So you've got to specifically get a test that includes the phosphorus in the test. It goes up first, typically once patients get to CKD4. And the first treatment is probably phosphate binder therapy and or dietary restrictions, depending on which you can get away with, or some combination of the two. PTH levels go up, and there are people out there advocating for aggressive therapy of the PTH level. But here is an instance of treating another lab test as opposed to treating the patient. And the issue is, does it matter? So here's where the heresy steps in. If you talk to experienced nephrologists who've taken care of lots of dialysis patients like I have, and mine's well over 2,000, and you say, have you ever seen anybody develop metabolic bone disease that was clinically important before 5 years on dialysis? The answer is probably no, or I remember one case out of that series. So it's rare. Most patients have to be on dialysis a long time. But the brutal fact of the matter is that the 50% survival rate on dialysis is 3 years. And a lot of the patients, these 60 some odd year olds with diabetes, don't last 3 years in most cases. So you got a lot of patients you're treating lab tests on and treating lab numbers on where it probably doesn't make much difference. So in those cases, what I would do would be to treat hyperphosphatemia to avoid secondary problems like itching or accelerated loss of kidney function. But I'm not particularly worried about PTH levels or metabolic bone disease. The young patient who has only chronic kidney disease would be the person I'd worry the most about. But experience suggests they're the ones that are least likely to take additional medications because phosphate binders have to be taken after every meal, after every snack, and the pill burden gets to be substantial pretty quick. So the very people who are most at risk and the very people you'd be most inclined to treat aggressively are the ones that's hardest to get it to do. The little old lady who's not eating much to begin with doesn't mind taking another pill because she's already taken 20, so 21 doesn't make any difference. So, I would start monitoring the phosphorus at CKD4 and treat the phosphorus levels accordingly, but I wouldn't get too worried about vitamin D and PTH, although the standard recommendation is to check them at least once a year.
Okay. Next question. Um, for cystatin C, do you use that for some populations or for some subpopulations to assess CKD?
Where the cystatin C measurement can be as helpful as in some reason for a patient where the number doesn't match up with what you think is clinically going on. So the little old lady who has no muscle mass, who has a creatinine of 1.5, may in fact have worse kidney function than the creatinine clearance would indicate. So if you're suspicious that that might be going on, then you can measure the cystatin C to get a better idea. And the converse is also true. The young, healthy bodybuilder who's been using the illegal anabolic steroids and had major weight gains, whose creatinine has gone up, if you check cystatin C, they may in fact not have had a change in GFR. So in the extreme clinical situations, I find it very helpful. In the average patient, I don't think it makes much difference because you have the advantage of looking at the patient. If they look normal in size and normal in body composition, creatinine is good enough for government work. If there's something about them that's strange that you're not sure of, then you can do that. It's a cheap test. It's about $17, and it can give you another calculated value. And studies do suggest that the combination of the two is probably the most accurate, but it's a precision where it doesn't make much difference because the question as to what you're going to do depends on how the patient is doing more than the lab test.
Okay. Next question, talking about serum protein electrophoresis. Can it be abnormal just due to low GFR?
See, the protein electrophoresis can be because the albumin level can be down because the patient's nephrotic. The issue comes up in older patients who are having unexplained loss of kidney function because there are a lot of people out there who have abnormal paraproteins. So if you do an immunoelectrophoresis of the serum and urine, you frequently find monoclonal spikes, sometimes isolated light chains. Yet they don't have any of the criteria for multiple myeloma, and we usually have a normal bone marrow biopsy if you go that far. So when nephrologists refer to that as monoclonal gammopathy of renal significance, and this is a real issue in the older population. I don't worry about it much in the 20 some odd year old, but the 60-year-old or the 80-year-old who suddenly presents with unexplained kidney failure is something to think about, because you might want to treat that patient more aggressively with things like steroids and that sort of thing than you otherwise would. So I don't do the test routinely, but I do it when I've got a clinical suspicion. If they've got uncontrolled diabetes and hypertension, I'm not sure I'm looking for another diagnosis for kidney failure in that patient very often.
Right. Should the dose of semaglutide be adjusted in CKD, and if so, at what threshold?
I don't particularly worry about the dose. I don't remember what the package insert has to say about dosing reduction, so maybe you can enlighten me on that because I haven't thought about it in a while. But generally speaking, I would start with the lowest available dose and to see how they do. The goal being to try to reduce the amount of proteinuria. The risk, of course, is that you might start having trouble with hypoglycemia, particularly in a non-diabetic patient.
Let me ask another question. You just mentioned about the older patients who are on dialysis. You said either half will have died within 3 years of dialysis. Is the cause of death coronary artery disease for the
You,
leading cause of death?
Yeah, early deaths. There's a 90-day mortality rate of about 25% in patients who start dialysis, and Medicare for non-Medicare patients doesn't kick in until day 91, so we don't count all of that. But mortality is in the range of 25%, meaning people you started on dialysis and probably shouldn't have are
Uh-huh.
included in that group. Bear in mind that if you hadn't done anything at all, half of them would have lived 90 days with just conservative care. So early deaths, meaning in the first 2 or 3 years, are disproportionately cardiovascular deaths. And patients who've been on dialysis 5 years or longer, which typically are younger ones, those are more infectious disease deaths as a rule. And the really long term, the long vintage, as we refer to it, patients who've been on dialysis 5 to 10 years, then you start seeing problems with things like amyloidosis and that sort of thing, which
Mhm.
cause vascular collapse.
So there's a premium on focusing on coronary risk
Yes.
factors for those and being super aggressive if you want to be
And
super aggressive.
the problem you get into is the one study that was done in Germany is called the 3D or 4D, I think it's 4D study, was looking at the effect of these drugs, and toxicities are perhaps slightly higher in dialysis patients than in other patients, but not much. But the benefit doesn't seem to be seen. And the thing to remember is a lot of what you see in coronary artery disease in dialysis patients is medial calcification because of the dystrophic calcification problem that we talked about earlier. So one of the arguments for being aggressive about control of calcium and phosphorus is to avoid that. The data that we can actually do that is non-existent in my view.
Okay. Let's see. Any other questions? Any other questions for Dr. Wright? So you had mentioned PPIs. At what stage, CKD stage, should you kind of avoid PPIs? Is it
That's a great,
one? Is it
great
two,
question.
three, four? I mean, they have lots of other downsides too, for long-term use, so or potential downsides.
Yeah, so the issue usually comes up in somebody that's been on a proton pump inhibitor for reflux for
Hmm.
forever, I mean, as
Yeah.
long as the drugs have been around, and the creatinine's gone up, and you do a biopsy or you don't do a biopsy. If you do a biopsy, what you'll see is interstitial nephritis. If you don't do a biopsy, what you do is you try to talk them out of the drug and see if they get better. And it turns out it's a real phenomenon, but not common. There are a lot of people taking PPIs who don't get kidney disease, but the ones who get kidney disease related to PPIs get better if you stop the drug. So what I would usually recommend is if somebody's been on a long-term PPI, try to get them to take a drug holiday to see how they do. If they're miserable and can't stand it, and other not conservative management for reflux symptoms doesn't work, let's say they got a Barrett's esophagus where they really need to take something,
Yeah.
then you may just have to buy that risk. So it's there, but how quantitatively important it is or not still debated.
And how long should that drug holiday be?
I'd suggest a couple of months.
Couple of months and then recheck.
Yeah.
Okay. Let's see. Any other questions? People are thinking about lunch in
Or their third
Connecticut.
cup of coffee.
Yeah. Any other questions? Let me see if anyone's got their hand up. Who's got their hand up? All right. All right. I mean, you gave us kind of the bottom line, your summary slides, but any other last words of wisdom before we let everyone go?
Yeah, if your patient has an abnormal lab test, you need to think about it, but you don't need to panic. There's usually plenty of time to figure out what's going on.
I also like the idea that's, sometimes less really is more as
Yes,
for our patients.
right now we're operating on the assumption that less is less, and that's bad, but it may not be.
Yeah. Um, all right. So again, thanks everybody for attending. Thank you, Dr. Wright. For those of you attending, if there are other talks that you are of interest, whether it's kidney related, um, please contact Kristen Talbot at the MAVEN Project, and she can set lots of other topics, whether they're related to kidney disease, endocrine, or any other topics that you'd like to talk about. Thanks again, everybody. Have a good rest of your day, and thanks again, Dr. Wright, for another great session. Take care,
You're
everybody.
welcome.
Bye bye.